Well, good morning, everyone. Thank you so much for coming to our third annual Williams Syndrome Program family event. I think most of you are very familiar with the MGH Williams Syndrome Program, but if not, we thought we'd do a very quick introduction. I'm Dr. Robin Tom. I'm a psychiatrist. I love working with kids and adults with Williams syndrome, and I provide psychiatric care as a psychiatrist and also do clinical research trying to improve mental health in people with Williams syndrome. I don't think Dr. Pober needs an introduction.
Well, just in case, I'm Dr. Barbara Pober. I'm a medical geneticist. As I like to say, I set up my first Williams syndrome clinic before many people in this room were born in 1987. So I've had the privilege of being involved in clinical care, but I also do clinical research related to natural history, how people do over time as they get older. Robin and I co-direct the MGH Williams Syndrome program, and it's a pleasure and a privilege to do so.
So for those of you who may not be so familiar with our Williams syndrome program, we really think of it as having three missions that are deeply interconnected, but all really important to the two of us. Of course, we provide clinical care, not only genetics and psychiatry, but we're so fortunate to be part of Mass General Hospital, where we have this deep network of many different types of specialists who are familiar with Williams syndrome and work with our patients right across the lifespan. So we're really fortunate to have those resources. I know many of you have participated in our clinical research studies. We really focus largely on clinical research at Mass General, focusing on improving how we diagnose conditions, providing information about what to expect across the lifespan in people with Williams syndrome, and also innovating new treatments. So thank you so much to everyone who's participated in research. And the reason we're all here today is to support our third mission, which is support and education. We know that not everybody with Williams syndrome can travel to Boston and Mass General, which is why we hold events like this. Thank you to all those who, I know many of you have traveled a long distance to come today, but please know that all of this information will be recorded and available on our website. In fact, this is not the first time we're doing this. We've done this twice before. If I know many of you came to our family events last year and the year before. But if anyone missed the events, all of the talks are recorded and available on our website. In 2023, our event focused on navigating adulthood. In 2024, we thought that was only fair to follow that up with the pediatric event. And for our third event, we thought we'd bring people right across the lifespan together and to focus on GI and feeding issues. Of course, none of the work we do would be possible without a large team. And I really need to thank Cherie LePage. I know many of you are very familiar with Cherie. She really did all of the work to set up our event today. And most unfortunately, she's on a cruise. So she's not able to be here today, but none of us would be here without all of her hard work.
So for those of you who all got an email from Cherie yesterday, she's working while she's on the cruise. That's typical for her, but she does so much more than just help with this event. She really helps coordinate complex care for local and for local patients as well as patients coming at a distance. That is, I don't want to say a thankless job, but it is an incredibly time-consuming, challenging job. But it's part of the mission we have tasked her to do because it makes it easier for you.
I also wanted to mention that Cherie services are all philanthropically supported. Um, and many of our other services as part of the Williams Syndrome program, including our Williams Syndrome social worker, Agnes Woodlock, will be, I don't see her here yet today, but she'll be here a little bit later, definitely during the lunch hour. So if anyone in the audience is interested in supporting the MGH Williams Syndrome program, Dr. Prober and I would be glad to speak with you.
Yes, just make the checks out to us.
We'd like to thank the Byrne family for their vision, dedication, and support of the MGH Williams Syndrome program. Dr. Prober has been doing this for a long time, but we really didn't have the vision and support to develop a more comprehensive program until we received philanthropy from the Byrnes. And we know that we're also thankful for the many other families that have supported our work over the years. Also, thank you. We have several volunteers who are helping out today. Kamaya at the front desk is the clinical research coordinator at Mass General, and we'll have several other volunteers throughout the day. Thank you to Sarah and the WSA. Sarah, thank you so much for traveling out to Boston today. We so appreciate your and the WSA's support in publicizing the event and also providing goodies for the adults with Williams syndrome. Thank you. So with that, we're really excited to introduce today's program. We have a lot of information about GI and feeding issues. I won't go through the whole program. You have it in your packets, but I did want to kind of highlight a couple of things. Talk 2, which starts at 11, will be the one concurrent session we have of the day. So if your loved one with Williams syndrome is 16 years or younger, we'd like you to just pop right next door because the talk next door will focus on children and the talk in this room will focus on adults. The other thing I wanted to mention was the lunch hour. We have something special planned for the adults with Williams syndrome. So we would ask that everybody pick up their lunches in the hall. Lunch will be served right where the coffee was this morning. So pick up your lunch and we'd like the adults to head next door for some special programming and an activity we have for them. And then welcome parents to stay and mingle in this room.
So yes, don't get too excited about lunch. It's a box lunch. So, but we thought that would be easier for everybody to work with. So we encourage the adults to bring their boxed lunch next door, and everybody else can stay here and eat and mingle. If you indicated a preference for your lunch, turkey sandwich or vegetarian, it will be on the back of your name tag. What you asked for at the time you registered. We suspect there's going to be enough to change your mind, but say if you did indicate something, we recorded that and are reminding you what that was.
And we'll be doing spot checks. So with that, I would like to introduce our first speaker. Our first speaker is Dr. Claire Zarkessler. We're so fortunate to have her open our program today. She is the medical director of the Pediatric Neurogastroenterology and Motility team at Mass General Hospital for Children. She runs the Pediatric Motility Procedures Center and also teaches fellows and residents about complex neurogastrointestinal diseases. She has vast experience working with people with Williams syndrome, and she also does clinical research focused on motility and functional disorders, particularly the treatment of gastroparesis and constipation. Welcome, Claire.
Okay, so I can get this started. Okay, good morning, everyone. It's good to see everyone. Nice to meet some of you, and I know some of you in the audience, so I'm glad everyone is here. I'm gonna spend some time this morning talking about some of the GI problems that we see in Williams syndrome. I'll leave some time at the end to kind of field some questions that people have. And there's a bunch of slides, so I'm not sure we're gonna get through everything, but I'm gonna try to touch on a few main points and then happy to answer questions at the end. So I'm just gonna start with, oh, here we go. The GI complaints that we typically see with Williams syndrome. And then I'll do a couple cases that we'll try to walk through and understand specifically what some of the diseases are that we see. So first, I just wanted to start off by running through the GI tract because I'll be referring to some things during it. I want to make sure we're all on the same page there. So one area I'm going to focus on is the esophagus, which is the feeding tube, essentially, that connects us, the mouth to the stomach. And this is where kind of food passes to get into the stomach. Then we have the small intestines, which is very, very long. And then we have the large intestines that we call the colon, where feces is formed, and then the anus where we defecate. I'm not going to spend much time talking about the liver and the gallbladder, but those are all components of the GI tract. So specifically, what are some of the GI complaints that we see and that we hear about? So there's a paper that was published last year where they looked at 62 people with Williams syndrome and 36 controls and asked them about GI complaints that they have. And they looked at it in the current GI symptoms and then also lifetime. And down here you can see the key here where this was more likely to have these symptoms, the odds of having it. And so the 3 pluses means that's significantly greater. So where that was notable was with abdominal pain in a lifetime was a big complaint, and also currently too. That was kind of the biggest complaint. Patients tend to see a lot of GI subspecialists and also have medications for GI issues. And then there are a bunch of other symptoms that patients complained about. You can see here the abdominal pain was 21 times more likely, and constipation was 12 times more likely with patients with Williams syndrome. And I just want to take a brief moment to talk about CRUISE, which is the Collaborative Registry for Williams syndrome. So it's one central place where they were able to collect a lot of data about Williams syndrome, and it helps us with research. We can keep the data, but we need everyone kind of to participate. So it's just a little plug that this is an important thing to be a part of. So please complete your annual surveys. And this is the data that we have thus far in the most recent registry, the CRUISE registry. And this includes 322 participants with a nice range of ages, some younger than 10, between 11 and 30, and then some greater than 30, and asking them about GI problems ever that they experienced. And here, as you can see, the most common ones that we're seeing were reflux and constipation, and that's what I'll focus on today. But then there's also a slew of other GI complaints that are certainly noted in Williams syndrome. So first, I just wanted to start with a case. So this is a 14-year-old male who's having difficulty with swallowing and that it's hard to pass food. Sometimes foods are worse with breads or chicken. He can have regurgitation, so food coming up into his mouth, and then he'll often be able to swallow it back down, but he doesn't really have forceful vomiting. And then he says that he can have some pain also in the chest area. The blood work's been normal, and he's gaining weight well. So the first thing we think about with patients who are having regurgitation and chest pain is reflux, which is GERD. So gastroesophageal reflux disease is the passage of the contents of the stomach up into the esophagus. And sometimes it comes all the way up into the mouth. You can spit it out or vomit it. Sometimes it doesn't. Infants can present differently. They can have more spitting or problems with weight gain. And the adults is where we hear more about complaints about pain or burning or regurgitation. It's one of the most prevalent diseases we see worldwide. Up to 27% of patients in the US will have reflux disease. Within Williams syndrome, with our prior registry, it was 67% reported in their lifetime. In the CRUISE registry, now we're at 55%. So a significant amount of people with Williams syndrome do have reflux disease. And around 25% of people with Williams syndrome are on medication for reflux disease. And just notably, there was an interesting study that was done not in Williams syndrome, but looking at the hiatal hernia, which is this area here that helps keep food in the stomach. And they noted that patients with reflux disease had lower elastic fiber, so elastin within that area. And those patients had more reflux disease. And so it's just an interesting way that we might think about Williams syndrome, that maybe there's a component of lack of elastin in this area that keeps that stays tight, and it might not be as tight in patients with Williams syndrome. This hasn't been studied within people with Williams syndrome, but just a notable area to think about. So in terms of evaluation, what do we do when we're evaluating for reflux? One of the things we do is an endoscopy. And some of you may have had that. This is where we take a tube that has a camera at the end. It's called an endoscope. And we go all the way in through the mouth, the throat, and the stomach and the beginning of the small intestines with a camera, and we look around and we see if there are any signs or symptoms of anything abnormal. And we can diagnose reflux disease sometimes if we see there's inflammation here in the esophagus or down in the stomach. Also celiac disease, which I'll talk about later, is also diagnosed this way. One of the drawbacks, though, particularly in people with Williams syndrome, is that it does require anesthesia. And anesthesia can be a significant risk, as we know, in people with Williams syndrome. It's 25 to 100 increased risk of death. So it's certainly something to speak about with the anesthesiologist or the cardiologist. I certainly have done endoscopies on patients with Williams syndrome. So it is a possibility, but it's something to kind of discuss. Another way that we assess for reflux disease is with something called ambulatory pH probe. And what that is that's something we put in the esophagus, the feeding tube, that can actually test to see how much acid is coming up into the throat. And there are two different ways that we do it. So one is we put this tube that goes in, you can see it here. It's connected to something out here, and it goes in through the nose, and it kind of sits in the esophagus, and you wear it for 24 hours. It's really skinny, so most people do okay with it. And it can check how much acid reflux is happening at the bottom of the esophagus and the top of the esophagus. And it can also see, even if it's not acidic, how much fluid is coming up into the esophagus. I was going through my slides and realized this was a mistake. It's placed without anesthesia. So that's a nice thing, that you don't need anesthesia to have this placed in patients that were worried about anesthesia. But in a lot of our patients with Williams syndrome, it can be anxiety provoking because it is a tube that is in the throat, and that can be uncomfortable for a lot of people. So it's something to note. We do have something else called the Bravo probe, which is this little thing you can see here, and you can see a picture here, that kind of we place with an endoscopy, and it just sits in there. So there's no tube coming out of the nose. You don't feel it because it's suctions to the wall of the esophagus. And that also can tell us about how much acid reflux we're having. The nice thing about this is you actually keep it there. It stays in there for up to 4 days. So we get a good amount of information over 4 days. But this one does require anesthesia. So things that we have to weigh out the benefits and the risks of it. Some of the treatments that we have for reflux are just weight loss can sometimes help. Exercise can help. Avoiding foods that can trigger the symptoms. Sometimes we'll put kind of cushions under the head at night so that you're more upright, and that could prevent the food or the acid from coming up. Not eating before bedtime, and then smaller portions. In terms of medications we use, antacids, I don't know if some of you have used them, but those are things like Tums, Mylanta, Maalox. They often can be used to just decrease any pain you're having. So we use them what we call as needed to stop the pain in the moment. Because what it does is it stops the acid from hurting the walls of the esophagus and the stomach. But sometimes people use them too often. So we try to make sure it's not used more than it's needed. Then there's something called H2 blockers, and those are things like Zantac or Pepcid that you may have heard of. The one issue with that is that your body can get used to that. So people will use it, but may feel after a week or two that it doesn't work as well because your body has gotten used to that dose. And then the last thing we use are proton pump inhibitors. And these are things you may have heard of like Nexium, Prilosec, and those are medications that work really well, but the newer data is showing that maybe they do have a little bit of risk with them when you use them for really long periods of time. So that can affect the bone growth, some things with the kidney over a long time. And so we always just have discussions about the medication. It's very useful, and I use it in many patients. We just discuss kind of the risks and the benefits ratio. And while we talk about the esophagus, I want to kind of talk about how it actually works, because in patients with Williams syndrome, we actually see that it can affect the functioning of the esophagus. So when we think about the esophagus, there's contractions that go through it. We call it peristalsis. Um, and we think about it like if you think about a long tube and you squeeze one end of it and things move through to the other end. So you see squeezing and then relaxation beyond it. And this is how food passes through. You get squeezing and then the food passes through. And at the very end, we have something called a sphincter. And what that is, that's a really tight muscle that stays tight until you swallow. It relaxes to let the food through, and then it tightens again. And so those are the two really important components of our esophagus and how they work. And this is just a picture of the sphincter at the bottom. So you can see it's really tight here, and then it will relax when the food passes through. One of the diseases I do want to mention during this is achalasia, because there are people with Williams syndrome who do have achalasia and have been diagnosed. We also see other patients who have symptoms of achalasia but don't actually meet the criteria for diagnosis. The presentation of achalasia, you can have vomiting, difficulty with swallowing, weight loss, and chest pain. There's some ways we diagnose it. You can do something called an upper GI series, or also an endoscopy. There are ways that we think about achalasia based on the findings we have in this. But the real way we diagnose achalasia is with something called an esophageal manometry test. And that's a test also where you put a tube through the nose into the throat. It's not very comfortable. And it shows us how the contractions of the esophagus are. So this is just a picture of it. And this is, we see, I'm not going to go through details of understanding it, but these are a big contraction. And then this band across the bottom is the lower esophageal pressure. And so you see there's a green, which means higher pressure. When you swallow, it relaxes. And then you get a green again, which means that there's a pressure there. And this is all done awake. So with achalasia, what we find the abnormality is, and these are three different types of achalasia, is you don't see that pretty diagonal line that I'd shown you in the last one. You either see sometimes no line or straight up and down line. And that means that you're not getting the appropriate contractions all the way through. Either you can get no contraction, or you can get that the whole esophagus contracts at the same time, and that doesn't actually push the food through. It kind of just sits in there because it's not being pushed through. And the other really important thing we see is this band at the bottom, that sphincter pressure, it never actually relaxes. And so even when you swallow, you still see this band. We don't see any areas here that relax. And so those are the two components of achalasia that we see that are abnormalities that make it really hard to swallow. There are non-achalasia abnormalities that I have seen in patients with Williams syndrome. And those are people who actually don't have these contractions here, but they do have relaxation of the lower esophageal sphincter. So they don't meet criteria for achalasia. And my thought behind it, although this hasn't been studied, is I think this is more related to an issue with the elastin in the esophagus, because they don't have the same, they dilate more and kind of aren't able to hold the food in and contract as well. And so we have seen this in patients with Williams syndrome, more related to the underlying issues with elastin as opposed to the diagnosis of achalasia. So something for us to look into further. In terms of management, we sometimes use medications. It's not recommended because it doesn't work that well. Then we have different ways we can treat it with the endoscopy, where we go in and we can either dilate that sphincter at the bottom or do surgery. This is a picture of how we can go in and do surgery here. And sometimes we actually go in with a surgeon from the outside and make cuts to that sphincter at the bottom. The important thing to know about it is what we don't want is we don't want to not treat it, because over time that esophagus gets really dilated, which is we can see sometimes. And so we want to make sure we treat it appropriately. And we don't have any way to really change those contractions of the esophagus. So really every intervention is for that sphincter at the bottom. So that was our upper esophagus area. A few side notes, sometimes we do see things like eosinophilic esophagitis, which is inflammation in the esophagus. We haven't seen that more frequently in people with Williams syndrome, but something to note. And then another aspect that we don't see necessarily more frequently is issues with motility in the stomach, which is how things move through the stomach and gastroparesis. And I'm happy to answer questions at the end about those things too. Moving on to a patient, SW. And this is a 29-year-old female with chronic abdominal pain. The pain is intermittent. It's usually in the lower abdomen, but can migrate to the sides or the upper area of the abdomen. There's no nausea or vomiting, and improves with pooping. We got an x-ray and it showed a lot of stool in there, a lot of poop. And the blood work showed that everything was normal. We didn't find anything abnormal. So I wanted to run through some of the causes that we see of abdominal pain with people with Williams syndrome, because this is a common complaint that we'll often see. And there's a wide range of things that we think about and that we can diagnose. So one of the most common one that we see is constipation, and that's one I'm going to spend a good amount of time going through. We also sometimes do see increased risk of celiac disease, diverticular disease. We'll see sometimes diarrhea, like an irritable bowel syndrome picture. Gallbladder disease is pretty rare. It's not necessarily seen more significantly in people with Williams syndrome. Sometimes there's a thought to be vascular insufficiency leading to pain. And then disorders of the gut-brain interaction is a newer term we use, but those encompass like irritable bowel syndrome or just chronic pain syndromes that we see in some patients. And then there's just sometimes we just don't know, or we don't have a diagnosis for it. So a little bit about constipation and Williams syndrome. It's very frequent, as I showed you in the graphs at the beginning. Up to 25 to 50% of people with Williams syndrome do complain or do have issues with constipation. Some gene mutations may predispose patients to more significant constipation. There's a lot of thought about pathophysiology, what might be causing this. There have been mice studies that looked at there was different amounts of ganglion cells, which are the nerves, in the rectum, with the very end of the colon, and also the air amount is different. But when they actually looked at how things move through, it moved through normally. So we're still trying to understand what might be the cause of the constipation. Also, embryologically, as the baby or fetus is developing, the kind of lining of the GI tract and the how it's able to contract are different due to decreased elastin. And this decreased elastin, we think, leads to more issues with overstretching and failure. So we think that the colon is kind of a tube, and if it doesn't have that elasticity, that ability to kind of stay contracted, it gets dilated, it stretches out. The way I think about it is if you have like old rubber bands or something like that that haven't been used that much, might not have enough elasticity in them, and so it leads them to just not work as well and be more stretched out. And sometimes we think about vascular insufficiency. We're still looking into that. We do know, though, speaking with patients or people with Williams syndrome, and also just in general, that it does lead to significantly decreased quality of life. So people who have significant and severe constipation, it really is debilitating. And so it's important for us to really treat it well and figure out ways to make people feel better. This is just the Rome criteria. That's the way what we diagnose, or how the criteria we have for constipation. There's a bunch of different things that we use when we think about giving someone the diagnosis of constipation, but it's usually related to how frequently they have bowel movements and the consistency. Is it hard? Is it less than 3 times a week? And some of the symptoms we see with constipation are abdominal pain, bloating, decreased food intake, particularly in our younger kids. Spending too long in the bathroom. A lot of people say they're straining, they're sitting there, they feel like they need to go and it won't come out. And then sometimes we'll see blood too in the stool. So this is our Bristol stool chart. Some of you may have seen this before. This is how we ask people, what does your poop look like? And we have all different ways to talk about it. I know for some of you this might be embarrassing, but I talk about poop all day long. And so this is small, hard balls of poop, which is, we think about constipation, and this is the opposite end. This is liquid. I'm going to show you a few different charts that they're available, but they've expanded on them to include different types of foods or different types of candy to associate with it. So it helps, with some people to how they can relate to their poop. So in terms of medications, I am going to spend a few minutes going through these, but happy to answer questions at the end. There's a wide range of medications that we use, and we use them in different situations depending on what the symptoms are. Bulk forming are ones that actually they actually add to the size of the poop, but sometimes that's helpful because stretching out actually makes the colon want to contract more. So those are things like fiber that we use a lot, and that's usually a first thing that people will use, just add more fiber to their diet, or fiber supplements. Our osmotic ones are the ones that actually bring more water in. So those will help keep water in the poop and so make it more watery. So it's a water shift. And those are things you may have heard of, like Miralax or lactulose, even magnesium supplements that a lot of people use that can help soften the poop and make it more watery. Then we have the stimulants, and those are things that actually cause the contractions of the colon. So that those would be things like Senna or Dopalax, and they help, particularly if we think the colon's just either stretched out or not moving things along as well. Those actually help with the contractions. We do get sometimes more pain with them, but I think they can be really effective with people who have colons that aren't working as well. We also have the rectal therapy. Those are like the enemas, the suppositories. We try to avoid those because those can be pretty hard for people to take and sometimes upsetting to use. And then we have the prescription ones. Those are the newer drugs that we use. And those are things like Amitiza, Linzess, and Motegrity that we use often for constipation. And I do want to spend a couple minutes talking about those because they've been around now for a decade or two and are used more frequently by GI providers in general. So this is called linaclotide, and that's Linzess. That comes in a capsule and it can be opened up. So we like it a lot, particularly in my pediatric patients, because who have difficulty swallowing pills. You actually can open up and put in water or applesauce. And so it's helpful because it's just little beads and you can just swallow easily. Usually we try to give it in the morning, but now with the newer data, we find other times during the day that we can give it too. There's a wide range of dosing, so we can always change the dose of it. And sometimes the question of if we can give it a food or not is still being debated. The biggest side effect is diarrhea. And honestly, I have in some of my patients, they'd rather have diarrhea than constipation. So they'd say, oh, okay, well, fine, I'll take that if that's the biggest side effect. But there are also ways for us to play around with it if that is an issue. And also the newer studies have shown that it can help with other symptoms besides just pooping. So with pain, sometimes it helps with, and with bloating. And the thing I wanted to mention here is last year it got FDA approved in pediatrics too. So we're really excited about that. It's the only constipation medication that's approved in pediatrics at this point. And so we feel very comfortable using it in our pediatric patients too. And then this is the newer drug. It's called prucalopride or Motegrity. You might have heard of it. Came out like a little over 5 years ago. It has been used in Europe for a very long time, but was approved in the US more recently. It works in a different way, but helps with kind of contractions of the colon. So it's the most of the drugs we have available. It's the one that actually pushes things along throughout the whole GI tract. So we sometimes try to use it for other issues in the GI tract with motility. And so we think it helps with the stomach and the small bowel too. Some of the side effects, it can be a headache, sometimes GI symptoms, and sometimes changes in mood. So we do monitor for this, but a lot of times those symptoms will wane once we stay in it for a while. And then, of course, I want to just mention the other parts that are really important, just dietary and lifestyle things that always come up. We love prunes. We always talk about prunes. Those can be really helpful with pooping. Milk and dairy intake. There's always this question, if you decrease dairy, is that going to help? It's mixed data. In pediatrics, there has been a study that showed that taking it out can really help kids, but sometimes it does nothing. So what I tell people is take it out of your diet if you want to, try it out for a week or two, and if you don't see any improvement, then add it back in. There's no reason to just keep it out indefinitely. Fiber also in pediatrics has conflicting results. Adults, they use it more often, but as I mentioned, it kind of bulks up that poop. So too much fiber actually can cause worsening constipation. And so we want to make sure we have a good balance of fiber in the diet or supplement, but not too much of it. That's causing too many issues with the poop. We don't have, based on our data, specific recommendations on water, because that's always a question too. But of course, more water is a great thing to have. So I'm never going to tell someone not to take water, but we don't have data to support that having tons of water is going to dramatically change the outcome of constipation. Also with probiotics, it's a hot topic these days. The data in motility and constipation for probiotics isn't there at this point to support the use of probiotics. However, there are many other areas within the GI tract that it can be beneficial. So I often tell people that they can try probiotics if they're interested and see if it helps them, because anecdotally, I do have people who say it helps, but we don't have data to say that this is a good intervention for constipation specifically. And then exercise is wonderful. We know that it helps move the gut along. It kind of helps with contractions. And so I always encourage movement. And then I want to spend a few minutes talking about the sequelae of constipation. So those are the things we see that happen after constipation once we've had it for a while. Hemorrhoids, anal fissures, rectal prolapse, and diverticuli. So just before we jump into that, I want to just spend a minute talking about what the breakdown of constipation. So one is how things move through the colon. So that is, we call it the transit time. So we have feces that come in here and they make their way all the way through the colon and get all the way through the end. So when I'm talking about contractions or a dilated colon, that's this area. But then things get to the end, the very end here, and we have to get them out. And so we have to push, we call it the bear down, we have to push. And there are actually mechanisms that need to happen at the end of the colon and the rectum that have to happen to get that poop out. So we need relaxation here of the sphincter. We need the pelvic floor to drop. And we need that pressure from above to get it out. And sometimes these muscles aren't coordinating well. And so we have issues with actually getting poop out. So people say, I need to go, it's there, and I can't get it out. And so we think about that more as a pelvic floor issue and outlet obstruction. And there are different interventions we do for that, but it helps us kind of differentiate the two parts of it. And this could be issues with straining and kind of really pushing to get that poop out. So rectal prolapse is something we do see with people with Williams syndrome. It's when the rectum falls and passes through the anus. So it's usually inside, and you can see it kind of sticking out at the end. And it can vary in size, and often it will come back once you stop pooping. So people will push, and that will pop out. And then when they stop pushing, it will come back in. Under 4 years of age, we're not as concerned about it because most will resolve on their own. But we do see a higher risk in people with Williams syndrome. The data that we have from the registry is a little over 3% will have it at some time during their lifetime. And we think that this is a similar mechanism to the mechanism that I talked about before with the hiatal hernia, that we think elastin might be lacking. And so again, it's kind of like floppier and doesn't have as much strength there. I also find, I've seen with my patients with Williams syndrome that sometimes they push really hard to go to the bathroom because we're so concerned about constipation. So we have them sit on the toilet and we say, push, push, push. We sit for a long time. And actually that pushing down, especially in this area that we think is lacking with elastin, actually can push that so much that it overcomes, and we kind of get that rectal prolapse to come out. So there are different mechanisms that we think. So it's kind of this balance between wanting to make sure that we're getting the poop out, but not pushing or sitting too long, that it causes more pressure on this area. Treatment, usually we wait it out a bit in the younger patients. The older ones, if the constipation treatment isn't working, then we do sometimes go to surgery. Another thing we see are hemorrhoids. So these are swollen and enlarged veins in the rectum and the anus, the very end of the colon. It can cause discomfort, bleeding, and we think it's due, again, to this increased pressure. We're pushing down a lot, and so the blood is being pushed there, and we get bulging of the vessels here. And it can be inside or outside the rectum. We see an increased risk, again, in people with Williams syndrome, and up to almost 7% will report some in their lifetime. So it's really important to ask about these problems in order to detect them and try to prevent them or prevent worsening in the future. And then diverticula are a big thing that are seen, and these are out pockets. You can see like the little holes, and here's a picture of them. They kind of have little out pockets of the colon, and we think this happens over time. And people without Williams syndrome also have this too, but we see it more often in people with Williams syndrome. We also see it at a much younger age than we see in the general population. And up to 8% of people with Williams syndrome will have diverticuli, with only 2% in the general population. And again, we think this is due to the elastin. It's not as, it doesn't have that elasticity. And so when there's pressure on it and when poop comes through, it kind of stretches it out, and you get these little out pockets that we see here. The interesting thing is most people with diverticulosis in general don't have symptoms. So we don't really know about it either until it gets infected or until we do a colonoscopy. So we do see a lot of diverticulitis in Williams syndrome, and this is just the percentage that there are a few studies that came out, and a bunch of them do go to surgery. And diverticulitis is when we get inflammation in the diverticuli. Majority of these happen in patients under 40 years old, and it's diagnosed with a CT. And then I do want to spend the last little bit talking about celiac disease and diarrhea. So celiac disease is an autoimmune disease that people are genetically susceptible to. Some of the symptoms, people have poor weight gain, abdominal pain, and it can overlap a lot the symptoms with like irritable bowel syndrome, which I'll get to in a minute. So it's sometimes hard for us to just diagnose it based on symptoms. In the general population, we see it around 1% of people, but in Williams syndrome, as high as almost 11%. So that's a really significant increased risk. So it's thought about now in people with Williams syndrome to look at it further and to always keep it kind of at the top of our minds. And in our published data on celiac disease, it's noted that people with Williams syndrome do have a significantly increased risk. And they note that they don't have an increased risk of having the genetic predisposition to it, but they have an increased risk of actually developing celiac disease when they have the genetic predisposition. So there have to be other factors we think that are playing into this. The diagnosis is made with a blood test. Initially, we can do a screening test. And then we also do endoscopy. But as we talked about before, there is an increased risk with the anesthesia. So we'll often just do the screening test initially, and there are other ways to diagnose it, not necessarily with an endoscopy. The big thing is if we're concerned about celiac disease or interested in it, you have to be having gluten in your diet to diagnose it. And so we need, a lot of times people take out gluten and say they feel better, but we can't actually make that diagnosis with the blood test or with the endoscopy, and so unless we feel confident that there's been enough exposure to gluten. And so one of the topics that are debated among those who provide care for people with Williams syndrome is about screening. And so the thought is to do, this is kind of the newest thought that came from some of the data that we have, is to do an initial screening. And that should be done in either infancy or young childhood if we can do it by 2 years of age. And that's looking at for the genetic predisposition to celiac disease and then also the screening markers that we have. If the genetic predisposition is there, if it's positive, then we do recommend doing screening every few years with the blood test just to make sure that we haven't developed celiac disease. If we have a negative, that's this HLA, if it's negative, the genetic screening, then we feel comfortable saying you're very unlikely to develop celiac disease and we don't need to do repeated screening going forward. So that's kind of the thought behind it now in people with Williams syndrome. And then I'm going to try to quickly go through this because I want to leave some time at the end for questions. The other thing we do see sometimes is diarrhea and irritable bowel syndrome. I don't honestly see it as often, but it is something that comes up at times. And what diarrhea is, it's increased volume of fluidity, so amount or the kind of looseness of the stool, or the frequency of the stool. We can have in a short period of time. So if it resolves over a couple of weeks, we think that's usually infectious. But if it stays around for a while, then we think about all these other things that it could be, and that kind of we keep in the back of our mind, like irritable bowel syndrome, but also Crohn's disease, ulcerative colitis, issues with malabsorption. And this is just what I talked about before, the Rome criteria, the way we diagnose things that I mentioned for constipation. This is the way we diagnose it for irritable bowel syndrome. The two main components are pain. You need to have some pain that's often relieved with defecation. And then you also need to have changes in bowel movement. Those are the two ways that we kind of combine to make the diagnosis of irritable bowel syndrome. So in order to make these diagnoses, we need to get a history. We do stool studies. We do blood tests. And the big thing about the irritable bowel syndrome, it's usually a diagnosis of exclusion. So we need to make sure there's not something else going on, like celiac disease, Crohn's disease, other things like that. So sometimes we'll have to do more tests, like endoscopies or colonoscopies, or more pictures or imaging. And then these are some things to think about it that would make you think it's not irritable bowel syndrome, like weight loss, bleeding, if you're having symptoms at night, all those things are concerning. There are a bunch of different medications we use. We try to initially just change diet and exercise, but then we do have medications like for constipation we talked about. For diarrhea, we have like Imodium sometimes we'll use, and there are other medications we use. And then we have a bunch of medications we use specifically for the pain in irritable bowel syndrome. I'm not going to go into details about that today, but we can kind of, I'm happy to answer questions if there are questions specific about the pain. So just a few take-home points. There are a lot of GI symptoms we see in adults and in children with Williams syndrome. Reflux, abdominal pain, and constipation are really the main ones, but we'll often see diarrhea and IBS. it's really important for us to differentiate acute versus chronic pain because it leads us down two different paths in terms of workup and what we want to do. We should always think about these other rare things that might be causing pain in people with Williams syndrome. And constipation should always be at like the forefront. Whenever a patient walks in with pain, I always want to think about constipation because even when we think we're treating it well, we don't necessarily have it under as much control as we think we do. And then another thing to note is that we always want to consider diverticulitis in the younger patients too. As GI doctors in general, we think about it in the older patients, but when we have someone with Williams syndrome, we really want to make sure that's also on our differential. And then the big thing is it's really important for everyone to talk about these GI symptoms because what I mentioned is untreated GI symptoms can progress to more issues. And so often if we get it earlier, we treat it earlier, we can prevent these issues from happening down the road. And so I wanted to make sure we had a little time at the end for any questions about anything related to this or other GI things that are coming up. Yeah, sure.
Just a couple of questions about medication.
Yeah.
You didn't mention Trulia.
I didn't.
Okay.
Not for any reason, just because I was trying to really get everything in there that I could. So yeah. Oh, sorry. The question was, I didn't mention a drug called Trulance. So in my initial slide deck, I had all of the prescriptions. So there's Amitiza and Trulance. I took that slide out just for interest of time. But that is also, so Trulance is a similar drug, works in a similar way to Linzess, linaclotide. It's not approved in pediatrics, so we don't use it as often, although insurance companies do want us to use it for some reason. The biggest thing about it is that they market it, and I have seen it causing less diarrhea. So there are some patients with Linzess that they get like clean outs, like they have a really big output of diarrhea just because they're very sensitive to it. And Trulance works in a similar mechanism, but doesn't tend to cause as much diarrhea. So I do have some patients who I will switch to Trulance if they can't tolerate the Linzess. That's basically the biggest difference between them.
Okay, thank you.
Yeah.
The other medication that I was wondering about for dysmotility, I wondered what you thought about erythromycin.
So I didn't get into gastroparesis, just again, interest of time, but that is a common medication we use a lot, and we use in pediatrics a lot. I like to get something called a gastric emptying scan just to assess how much motility issues we have, because it is an antibiotic, and I don't love to put someone on an antibiotic for extended period of time if we don't know if it is necessary, but we use it at low doses. It should be used at low doses. At higher doses, we often find that it can cause cramping and abdominal pain, like an antibiotic does. And so we use it at lower doses, both to prevent the kind of antibiotic resistance, but also the side effects. And the other thing to note about it as a drug is that it can, similar to the reflux medications I talked about where it loses its effect with time, it can also lose its effects. So what we'll often do if someone is staying on it for a long period of time is we'll start to cycle it, where we take a little time off so that when you restart it, it has more effect. Yeah.
My brother was adult Williams syndrome, severe achalasia, he had surgery, but he keeps on needing dilation. So I'm just wondering,
oh, interesting.
Lower elastic.
Yep.
Will you always need dilation, and how many times can you do the dilation because of the risk of dilation?
Yeah.
And also, are there any other treatments?
Yeah, it's an interesting question because I don't know his case specifically, but the thought of the dilation is just to stretch out that sphincter at the bottom. The thought of the POEM and surgical Heller myotomy is that you actually cut the muscle, so you shouldn't need as many dilations. So I do wonder if there's a role to go back in surgically and actually make a bigger cut or a longer cut to actually make it wider, because the goal of in achalasia is to make it so wide that food kind of just drops in. Not too wide that we have more food coming back up, but that happy balance. So my concern with repeated dilations, not that it's an issue, but with anesthesia, it is a concern, is that maybe there's a role to just make it a little bit wider so you don't have to keep going in for the dilations. We typically, if someone's needing that many dilations, we'll often go back in surgically. Yeah.
So if we're suspecting the possibility of lactose intolerance, what do you suggest to do at home before addressing the doctor?
Yeah.
And also the second question is, if there is a possibility of diverticulitis, what are the symptoms?
Yeah, good question. So for the lactose intolerance, There is a way that there's two ways we diagnose it. One is with something called a breath test, which is a pretty extensive, it's a 4-hour test. You have to breathe into something every 30 minutes. Another way we diagnose is with an endoscopy. So if you are having an endoscopy, they can take a sample to look at it there. But often what I'll tell patients, depending on how significant the symptoms are, is take lactose out of the diet and see if things improve. Sometimes we use lactate pills also, which you can buy over the counter. And those try to give extra of the enzyme that's missing. And in some patients, it works really well. And so if they are, lactose intolerant and they really want a piece of pizza, sometimes they'll take it before and they feel better. And so there's a bunch of things you can do before actually doing testing. Some people want that test to get the result and have the diagnosis. Some people just take it out of their diet and they feel better and they don't feel the need to get a diagnosis. I don't feel strongly one way or another. I don't need patients to get the diagnosis of it if they're able to manage at home with dietary changes that make them feel better.
So she's already on gluten-free diet.
Okay.
But she takes milk. Well,
yeah.
So take the lactose out.
Yeah.
So the milk or
yeah. So it's not related to gluten. It's in dairy products, but there are a lot of dairy products these days that are lactose free. So there's lactate milk, they make lactose free cheese. There's a lot of lactose free things. So what I might say is try a couple weeks and just buy those lactose free things, and see how she does with it. And you can play around with the lactate pill too and see if that helps her. And if you feel like you're not making progress, then it might be beneficial to see someone to get more testing. Oh yeah, sorry. And the diverticulitis, that's a tricky one because diverticulosis, having those little out pockets, there's no symptoms to it. So a lot of adults without Williams syndrome will not have any symptoms, and they go for their colonoscopy at 50 and they find them. And that's the same thing, although we just see it younger in people with Williams syndrome. So to do a screening colonoscopy isn't really necessary. It's more from our perspective to have it on our differential, or think about it if someone's presenting with severe pain, that is in younger patients, it is something that should be thought about, as opposed to in the general population, we don't think about it until they're older.
So yeah. I'm going to be the bad guy. One more question,
okay.
Please.
Okay, yeah.
Please repeat the question.
Oh, I'm so sorry. Okay. Yes.
Just a really quick question about, there was a slide that showed that abdominal pain.
Yep.
Prevalent in people with Williams syndrome.
Yeah.
Is that an umbrella term for all abdominal pain, including nausea, or is nausea distinct?
That's a good question. This is from the registry. So
no.
Oh,
that study.
Oh yeah, that was the study at the beginning, the Boker. Yes. Yeah. I don't know if it included nausea.
That's a great question.
And it's just as a side note, they've actually done studies that actually abdominal pain and nausea sometimes come from the same area in the brain. And so it's hard sometimes for patients or people in general to differentiate the two. And some might call it abdominal pain, some might say nausea, but it could be an overlap of the two. So I feel bad. Can I just do one more?
Oh, one more? All right.
I'll just do one. I feel bad.
Yeah. Just your thoughts on the use of antibiotics for a diverticulitis flare versus just managing the pain.
I would, so I'm not adult GI. So I'll preface that I don't see diverticulitis very often. Okay, she might be better to answer that. Do you have an opinion?
Antibiotics for a if it's a diagnosed diverticulitis flare, that I read it always gets treated.
My only opinion would just be based on the data I see in Williams syndrome is that a fair amount do go to surgery for it. So I would err on the side of antibiotics just because we know there is an increased risk. Particularly, we know there's an increased risk of diverticulosis in general, but we know that colon itself is not as kind of in the appropriate alignment. And so I would probably err on it just based on the data we have, but not my experience of the adult population.
Can we thank Dr. Zara Kessler for an amazing talk? Thank you. That was a tour de force. All right. So I'm actually going to see if the AV guy is listening. Do you have a laser pointer? That's a test. Because this Oops, does not. All right, so now we're testing my tech skills. Give me one sec. Aha.
Laser pointer.
Let me get the next slide. Presentation up. Laser pointer there, that one has
Be
it.
careful.
Yes.
2B.
Correct. So as you'll see, I didn't get the clothing memo. To say, as will be obvious in 1 second. So the next presentation, of which I'm a fortunate participant, is feeding issues and potential eating disorders in adults with Williams syndrome. So Dr. Ashley Dunford is going to speak first. Dr. Dunford is a clinical psychologist at the Mass General Hospital Outpatient Eating Disorder Clinic. She is a researcher and provides eating disorder treatment also for all ages. So.
All right, hi everyone. Yep, I'm Dr. Dunford, clinical psychologist, and I'm excited to talk with you guys a little bit today about.
You know what, and I'm sorry, I'm going to interrupt for just 1 second. So the parents of children under 16, you are encouraged to go to the smaller room to the left. My apologies for not saying that right away. I am so sorry.
No, it's okay. All right, so in terms of our agenda, we're going to provide an overview of eating disorders, eating behaviors that are common in adults with Williams syndrome, and then talk about treatment considerations. All right, so first I'm just going to provide a brief overview of eating disorders. So we know that eating disorders sort of exist on a spectrum, meaning that on one end, we have folks who are able to eat pretty normally, intuitively, meaning that they know when they're hungry, they know when they're full, and they're able to really kind of listen to their body to make decisions about food and eating. On the opposite end, we have clinical eating disorders, things like anorexia, bulimia, binge eating disorder, ARFID, which I'll talk more about. And these are often really impairing for folks because it not only causes medical issues like low weight or sometimes GI issues, but it can also cause issues with their daily functioning. So, not being able to follow regular eating schedule or having issues having food choices when they live their day-to-day lives. And so everything we see here kind of exists on the spectrum. Some folks fall in the middle, and that's what we call disordered eating, meaning that sometimes people have struggles with like maybe overeating or undereating or picky eating, but that doesn't necessarily mean that they meet criteria for an eating disorder. In order to meet criteria, you have to have a lot of what we call significant impairment, meaning it really has to have a really negative impact on your day-to-day living. In terms of prevalence, so we know about 9% of the US population, or 28.8 million Americans, will struggle with an eating disorder at some point within their lifetime. So in terms of common eating disorder presentations, I have listed here anorexia, bulimia, binge eating disorder, and then avoidant restrictive food intake disorder. And I'm just going to take a moment to briefly talk a little bit about each of those. So the first is anorexia nervosa. So this is an eating disorder that is characterized usually by really low weight and often has a lot of medical complications. Usually in terms of adults, that means that people have a body mass index, usually less than 18.5, which is sort of that minimum cutoff for kind of a normal BMI. And then also for kids and teens, it usually means that they're below the 5th percentile in terms of their BMI. Individuals with anorexia can have trouble gaining or keeping weight for a variety of different reasons. One could be a really strong fear of gaining weight. So worried that if they were to change their eating, that their weight would increase. Or there is a fear of, potentially doing behaviors that stop weight gain. So for example, some people will do things to prevent weight gain, while others may actually do things to actually stop weight gain from happening. So we see different behaviors, things like restriction, where people try to limit the amount or the type of food that they have in order to lose weight. We also see behaviors like excessive exercise, where people are moving around a lot in order to burn calories. And oftentimes people with anorexia don't really know the severity of their illness, meaning that they might know that they have a problem, but they may not fully understand how bad it is. And like I said, it can cause a lot of really severe medical problems, things like malnutrition, low weight, heart issues, bone density issues. So it can be really problematic. And we know that there's two different versions of it. One is the restricting type. So where we see folks typically trying to restrict the amount that they eat or the quantity or variety of what they eat. And then there's also binge purge type, which means people have these episodes of loss of control eating where they kind of eat an abnormally large amount within a short period of time, and then engage in what we call compensatory behaviors, being self-induced vomiting, taking laxatives, excessive exercise, in order to make up for the calories that they consumed. All right, the next eating disorder I want to talk about is bulimia nervosa. So similar to the binge purge version of anorexia, bulimia nervosa is characterized by binge episodes. So again, eating kind of an abnormally large amount of food within a short period of time and feeling a loss of control, feeling like it's really difficult to stop once you start. And oftentimes people will feel kind of guilty or upset about these behaviors that can cause them a lot of distress. Oftentimes people with bulimia, they'll again engage in what we call compensatory behaviors. So things like self-induced vomiting, using laxatives inappropriately, purging, etc., in order to make up for those binge episodes so they can prevent weight gain. In order to meet criteria, you have to have at least one of these episodes once a week for at least 3 months. Something to note about bulimia is that it's very similar to anorexia in the sense that people often are really kind of upset about the way that they look and they want to change either their weight or shape. So the difference between someone that has bulimia versus anorexia is someone with anorexia typically tends to be pretty underweight, whereas they can still share the same symptoms. All right, and then another one I want to talk about is about binge eating disorder. So binge eating disorder, like bulimia, is characterized by binge episodes, but the difference is that people don't engage in compensatory behaviors, meaning people are not doing self-induced vomiting, excessive exercise, laxative misuse, etc. They are just experiencing the binge eating episodes. And usually when people experience binge eating, they have symptoms like eating really fast, eating until they're uncomfortably full, eating when not hungry, eating alone, or feeling kind of guilty or upset about their eating. And similarly, like bulimia, it has to occur 1 episode per week for at least 3 months in order to meet criteria. All right, and then the last eating disorder I want to talk about is avoidant restrictive food intake disorder, also known as ARFID. So ARFID is a little bit different from other eating disorders in the sense that people with ARFID tend not to care so much about their weight and shape. Instead, they tend to restrict or avoid certain foods for other reasons. Typically, that means because they might have what we call sensory sensitivity. So they may have certain issues with tastes or textures or smells. Oftentimes these folks will find like fruits and veggies to be really bitter, or might find, mushy textures like bananas or mashed potatoes to be kind of uncomfortable. or they might be really bothered by other things related to food, so that may limit how much food they eat, as well as a variety of food. Another presentation is what we call fear of aversive consequences. And basically what this means is that sometimes people have scary experiences with food where they might choke or vomit or have allergic reaction. And that may cause them to avoid a certain type of food or stop eating altogether. And then the last presentation is what we call lack of interest in eating. So these are for folks that eating feels like a chore. They might be really forgetful about eating. They may have trouble eating enough food because they get full really quickly or don't have much of an appetite. And so sometimes that can also cause issues with both the amount of food that they're eating, but also the variety. Some other things to note is that with avoidant restrictive food intake disorder, it often causes problems like not getting enough nutrients or minerals. Sometimes people will have to rely on like nutritional drinks like Boosts or Ensures to help meet their nutritional intake. And it often causes problems some way in their life. Either it causes problems for the patient or sometimes for the parent. So an example of a problem might be like having to bring your own food everywhere because you're limited on your choices. Or having to constantly set reminders to make sure that you're eating on time. So just want to take a moment to talk about how ARFID is a little bit different than picky eating. So picky eating is a term that we hear more commonly, and picky eating is something that we can all experience. It's a part of growing up. It's really common in toddlers and preschoolers. It often gets better as kids get older and they have more exposure to food. And it's usually linked to things like food preferences, like likes or dislikes, whether or not a food is new, or specific textures or tastes. And usually these don't really cause major issues in their life. Whereas someone with ARFID or avoidant restrictive food intake disorder, this can happen in kids, teens, and adults. And sometimes it starts when people are really little, sometimes it starts later in life. And this is essentially is the ongoing avoidance or refusal of many different foods. It can cause weight loss, slow growth, not enough nutrients, and reliance on, again, this kind of supplemental drinks in order to make weight. It can often cause daily life to be harder. Like sometimes it can be hard with eating with friends or family. And like I said, it's usually related to kind of one of those presentations of the sensory issues, fear or low interest. Sometimes people will have all presentations, sometimes they'll have two, and sometimes they'll have one. All right, and so I know a lot of people are curious about, do I have an eating disorder or do I know somebody that has an eating disorder? And so there are a lot of questionnaires out there available that ask these sort of questions, asking things about feeling out of control with eating, worrying about your weight or shape, avoiding foods or certain meals, or feeling upset or guilty after eating. And these questionnaires, for example, the ED15, asks about how often these things are happening. And so oftentimes we want to kind of assess, what are the symptoms and how often are they happening to see what sort of problems they cause. I will say if someone is concerned about having an eating disorder or a loved one having an eating disorder, that it'd be good to talk with a healthcare professional because they can actually diagnose you. So I'd recommend if you are completing a screener and you have some concerns to talk with your doctor about that. All right, so I'm going to pass it over to Dr. Pober.
She'll be back. As you can see, I didn't get the white shirt, gray sweater memo. Okay, so why consider eating disorders in adults with Williams? It's like they'd never been considered before. Let's see if we can get that. So it's well known, and you've probably all lived through common feeding problems in infants and children with Williams syndrome. As we follow people over time, I and Dr. Tom in her clinic, we started hearing more and more about unusual diets, odd eating patterns. So that was sort of like clinically, is there unrecognized eating problems in adults? And again, part of my thinking was maybe, a leopard doesn't change its spots. If there are common eating problems in children, maybe in some folks these persist. Or if they were vulnerable to eating problems when they were younger, might they again be vulnerable to eating problems as adults? So we addressed this through our SHAPE study. So some of you not only have heard about the SHAPE study, some of you participated in the SHAPE study, for which we are very grateful. This was only for adults, so if you didn't hear about it, your child may not have been over 18 at the time we ran that. And the main purpose of the SHAPE study was to identify factors contributing to differences in body shape and weight, again, in adults with Williams syndrome, and differences in body composition. So the SHAPE, the word SHAPE, was an acronym that we spent several hours coming up with. So each letter stands for something. This was an aspect that we were going to interrogate to try and understand, say, differences in body shape and weight and body composition. So the S was for strength. So we looked at muscle mass. H, hormones. Was there a hormonal component to some of what we were seeing? The two A's, activity, so physical activity levels, adiposity, so percent body fat, the P for DNA programming, so trying to look at some genetics, and then relevant for today, the E stood for eating. In this initial part of the SHAPE study, what we call phase 1, it included 82 adults with Williams with an average age of 30. And we did look at their diet. That was one of the components of eating that we looked at. And for the sake of time, I'm not elaborating on the diet, but as one colleague said to me, this is the SAD diet. And I said, SAD diet? Have I missed this? Mediterranean diet, Atkins diet, but I've never heard of the SAD diet. Well, as she said, no, the SAD diet is adults with Williams eat the standard American diet. So the much less fruit and vegetables than you'd like, much more carbs, sugar sweetened beverages. But it turns out exactly like the average American diet. So the diet on average in adults with Williams is like most Americans' diet. But that is not the focus of today. In addition to collecting diet history, we administered the food-related problem questionnaire, which rolls off the tongue much more readily as FRPQ. So this asks a number of questions, and the questions basically organize into 4 categories. Is there preoccupation with food? Is there impairment of satiety? That means people aren't getting full when they're supposed to be getting full, or when it seems appropriate to be getting full. Do they take and store food? And is there an inappropriate response to certain food situations? So by and large, on average, again, from these 82 individuals, we had low to moderate endorsement for all of these categories. And doing something one isn't supposed to do, we sort of deconstructed this and looked individually at some of the questions to get a better flavor, pun intended, for what was going on. So in the preoccupation with food category, there's a question talking about food. So 90% talk about food. Now, some a lot, there are folks who are not done with breakfast before asking what's for lunch. For the majority, it was sort of lower level or intermittent interest in food. Impairment of satiety, one of the questions, still feels hungry after a normal sized meal. And another question was, given the opportunity, eats more than a standard size meal. So the endorsement for both of those questions was about 70%. So again, that's on average, it was sort of low to moderate endorsement, meaning a few folks scored really high on those questions or endorsed them with great vigor. The majority was sort of a lower level impairment of satiety. Takes and stores food, so 87% had some level of behavior consistent with helping themselves to food they should not have, whereas 40% were hiding or hoarding food, some a lot, a few occasionally. And inappropriate response, so the majority, just over 50%, become upset and angry if a meal includes a food not expected. So all of these are just behaviors, they're not diagnoses, but the frequency with which we were hearing about some of these behaviors made us feel we needed to systematically look, might there be eating disorders in adults with Williams syndrome? So we did phase 2 and had 86 adults. Now you may think we added 4 more to those 82. Wasn't the way it worked. Everybody who took part in phase 1 was invited to do phase 2. About half took part, but at the same time, we invited new participants as well. So 86 folks took part in this aspect of the SHAPE study, a slightly older age cohort, 34 and a half years. So we administered 2 screening surveys. You heard Ashley mention the EDE survey. We gave the EDA, it's an eating disorder assessment on online survey that broadly screens for a range of eating disorders. And we also gave the party survey. I'm sorry to be skipping around. The next slide shows you what the party is. But it is a survey to specifically interrogate for a smaller number of eating disorders, including ARFID. So we modified these surveys. The party is a questionnaire like an SAT test. You're supposed to complete it yourself. We obviously changed that to an interview. And for both surveys, rather than just talking to the adult with Williams syndrome, we did this as a tag team, the adult with Williams syndrome and their parent, usually the mother. The adult with Williams syndrome was supposed to answer first. And then there was a lot of negotiating between the adult and the parent. I mean, so you really have, an apple every day? I don't think so. So it's a consensus response that we got from the adult and the parent during these interviews. And I will explain screen positive in a second. So starting at the top, we have, as I said, 86 folks. That's where I have to turn around, use my other mic. Started with 86. We modified these 2 surveys. We also did a diet survey in terms of what you eat, showed some pictures, and collected a medical history questionnaire so that we can know what medications people were on, had they had surgery 2 months ago, which is why they weren't eating well, etc. So 24 of these 86, so that's over a quarter, screened positive for a possible eating disorder on either this party survey or the E-5. So what do I mean by screening positive? So it's like a mammogram is a screening test. It's not a diagnostic test. If there's a spot on the mammogram that says, oh, maybe there's something going on, and then you proceed to diagnostic testing. So because of the way we administered these surveys and the nature of the survey, we're considering these screening tests. So we're not diagnosing all these people. We're raising the possibility that there may be an eating disorder. And the majority of the subjects did not screen positive for a possible eating disorder. So when we follow this down, the specific categories that we saw were 7. There was concern about ARFID. The most common were binge type disorders, rumination, and one did not fit into any of the recognized categories. Of as much importance, only one of these 24 had there ever been the possibility raised that an eating disorder could be present or was present. So the party questionnaire, I sort of beg to differ. I don't think it's that short, but there are a number of questions getting at the core features of the ARFID diagnosis. And then there's scoring to see if you pass a certain or above a certain threshold. So I just want to, I hope it doesn't show up all that well, sorry. I want to make it clear that in the majority of folks who didn't screen positive, there was still a lot of stuff going on, a lot of arguments at home about food. This wasn't about clothing or weather. 20% taste sensitivity. Eating is viewed as a problem. Texture sensitivity, forget to eat, sensitivity to appearance of food, etc. So I just want to make it clear that any kind of eating tension or problem does not mean, oh, you've got an eating disorder. We're going to raise concern about that. There's still a lot going on related to eating, even in the majority of the folks who took part in our study. There's still a lot going on again in the screen negative portion of the study cohort. So our next steps, we would like to follow up with 24 folks who screened positive and have an expert like Dr. Dunford evaluate them. Are these screeners accurate for our population? There we go. The screeners have not been used. They're for general population. They haven't been applied before in folks with Williams syndrome. So this is challenging when you do a study on 86 adults with Williams. They don't all live in Boston. We do these at conventions, so people are from all over. So logistically, it is very challenging to re-engage and do follow-up research. But we think it's a really important study, and why it's important is to raise awareness about the possibility of eating disorders, because earlier treatment does lead to better outcome. And then the people who are going to talk about treatment are going to come on up.
All right, so I'm back just for a little bit. So I'm just going to briefly talk about treatment or psychotherapy for eating disorders. So there are two different therapies that are commonly used to treat eating disorders. One is called cognitive behavioral therapy, or CBT, and the other is called family-based treatment, or FBT. And for folks with Williams syndrome, we often recommend an FBT approach, just because we want parents and caregivers to be able to really supervise all of the eating that goes on, and to really be able to support their child as best they can. So I want to talk a little bit about what family-based treatment is. So basically what that means is that when folks have trouble eating on their own, maybe they're not eating enough food, maybe they're eating too much, maybe they're having difficulties meeting their nutritional intake. Sometimes we have parents or caregivers kind of take over until the patient is able to demonstrate that they can eat autonomously or eat on their own, and to be able to take care of themselves. So typically the way that it works is that there are 3 phases. Phase 1 is where parents take control over eating, supervise all meals, will plate the meal, will cook all the food. And then phase 2 is working towards giving the patient back their autonomy and making choices about what they're eating, or maybe helping out with cooking or helping out with plating. And then phase 3 is addressing some of the underlying issues that might have caused the eating disorder in the first place. Something to note is when we think about family-based therapy, we remind people that the patient is not the eating disorder. So what that means is, like, if somebody had cancer, we wouldn't say Bob is cancer, we would say Bob has cancer. Whereas someone with the eating disorder, the same thing. We wouldn't say Sally is an eating disorder, we would say Sally has an eating disorder. And the reason why this is so important is because folks with eating disorders will often really get upset when their control or choices over food is taken away. So we might see people, either kind of yelling or screaming, or not really talking at all, or even refusing to have different foods with their meal. And the reason why we talk about the separation between the two is because it's really not necessarily the patient that it's getting upset. It's really the eating disorder that's getting upset. And so we really encourage parents and caregivers to keep in mind that it's probably not just their child that is exhibiting these symptoms, but rather it's the eating disorder that's really fighting back. So with family-based treatment, not only do we have caregivers kind of take over all meals and snacks, but we want to engage in what we call regular eating, which is 3 meals, 2 to 3 snacks per day, eating every 3 to 4 hours. And we want to learn about kind of what sort of things are keeping the eating problem going. Is it because they're not eating enough? Is it because they have really picky eating? Is it because they're eating too much? Or maybe they're only eating certain types of foods. And part of treatment is kind of really being able to notice and work on tough feelings, challenging any food rules that people have. So people might have a rule of, like, I can't eat past 7, or I can only have this many calories per day. And so really helping people challenge those rules and become more flexible with their eating. We will also address things like fears of weight gain or body image concerns, as well as kind of helping figure out kind of, how to help the child or the adult get back to their normal life so that the eating disorder isn't running things for them. And then the last component is that we talk about ways to stay healthy and to avoid relapse. So thinking about, what sort of things do we learn in treatment that help the patient be successful, and how do we make sure this doesn't happen again? Another form of treatment for eating disorders is cognitive behavioral therapy for ARFID or CBT-AR. So this is a therapy that is specifically designed to help folks that have the picky eating, the sensory issues, lack of interest, or have had really scary experiences with food. And really the goal is to help people either increase the amount of food that they eat or the variety of food that they eat. So as a reminder, people with ARFID sometimes don't eat enough food, or they only eat certain types of food because they've either had a negative experience or maybe they have issues with picky eating. It has 4 steps. The first step is providing education to the patient and family about the eating disorder. The second step is treatment planning. The third step is doing food exposure, where we basically have patients test their anxiety or be exposed to foods that maybe they're fearful about or they've never tried before, or kind of learning to be comfortable with like tolerating fullness or nausea, because sometimes that happens when we eat a lot. So really the big part of CBT-AR is to really face those situations or foods in order to be able to overcome that anxiety. And similar to family-based treatment, we have people follow a regular eating schedule. We have them kind of log their meals and snacks, so we get a sense of kind of what types of foods and how much they're eating. And we recommend that, so there's an individual format and there's a family supported format. And so we typically recommend that we do sort of a family supported format for folks, patients with Williams syndrome. All right, and I'll pass it along to Dr. Tom.
All right, so I'm the only thing standing between you and lunch, so I will try and be brief. Sarah and then lunch. Okay. Well, I was joking, but not really. I think this part of the talk will be much shorter because really the mainstay and cornerstone treatment for eating disorders is psychotherapy rather than medications, but I did want to just briefly touch on medications. Important to know, though, that we really don't have any scientific data on treating eating disorders in people with Williams syndrome. So everything I'm going to be saying today is based on what we know from the general population. So what I'll do is I'll just briefly go through the 4 main eating disorders and talk about what we know and what we don't know about medications. So first we'll start with anorexia nervosa. The takeaway for anorexia is that we actually have a ton of research now in the general population showing that medications really are not very effective. They're not helpful for anything. They really don't support weight gain. They don't support the psychological symptoms of anorexia, such as the body image distortion. And if people have anorexia plus something else like depression or OCD, it's not even really helpful for those symptoms. And the thinking behind that is that people with anorexia tend to be so underweight, so malnourished, that their brains really can't benefit from medications until they're more refed. If a medication is used, because there are so many medical complications that can come with anorexia, it's really, really important that the patient's getting very close monitoring for any side effects that can happen with medications. And the one I want to highlight for Williams syndrome is patients with Williams really need to be getting frequent electrocardiograms to monitor one of the heart intervals called the QTC interval. That can be longer at baseline in people with Williams syndrome. It gets longer if you have problems with your salt balances in your blood, which is common in people who are malnourished. So that's something to really be keeping in mind if you're using medications for someone who has Williams syndrome and anorexia. We have better news for bulimia. Actually, there is evidence supporting the use of antidepressants for bulimia nervosa. The medication that's FDA approved is fluoxetine, brand name Prozac. And what we know from the general population is that higher doses do tend to be helpful. For binge eating disorder, which I'll remind you, we learned from Dr. Pober, is probably one of the more common eating type problems in people with Williams. There is one FDA-approved medication for binge eating disorder. That's a medication called lisdexamfetamine, brand name Vyvanse. If you've heard of Vyvanse, you probably have heard of it more in an ADHD type situation. It's a stimulant medication, and there have been trials showing that Vyvanse can be very helpful in reducing the frequency and severity of binge episodes, as well as reducing weight in the general population. We do use stimulants. I prescribe stimulants fairly frequently in my Williams syndrome practice, but I'm always monitoring my patients really carefully for side effects. You can see the side effects on the slide here that I'm monitoring for, and several of them are very relevant to patients with Williams syndrome, particularly anxiety and then an increased blood pressure. The other side effect that's not on the slide, but I always talk to my patients about if I'm using a stimulant, is that stimulants can make people with Williams syndrome sad. And that's something that we don't typically expect, because I don't see it in my patients with autism or my more neurotypical patients, but I think it can happen in roughly 1 in 3 or so patients with Williams syndrome. So that's something we want to be careful of. How does lisdexamfetamine work for binge eating disorder? We're not totally sure, but we think that it's more around decreasing impulsivity and some of those ADHD symptoms that may predispose someone to binge eating episodes rather than appetite suppression, which is a known side effect of stimulants. Antidepressants can also be helpful for binge eating disorder, so sometimes we use that. And then depending on the specific patient and their medical profile, there may also be a role for anti-obesity medication. Last but not least, we're going to talk about ARFID, which again is one of the more common eating type problems we think in people with Williams syndrome. ARFID is actually a newer eating disorder diagnosis. It was added to the last version of the DSM, which was published now about 12 years ago. So we actually have far less research in ARFID compared to anorexia, bulimia, or binge eating disorder. So I really recommend families can lean on those psychotherapeutic approaches like CBT for ARFID specifically. When kids and adults are coming in with a diagnosis of ARFID or even kind of symptoms of ARFID, what I'm really concerned about is making sure that they're not malnourished. So making sure that we're doing labs to make sure they're not anemic, or making sure they don't have vitamin or mineral deficiencies, because it's really important to treat that. We do sometimes use a medication called cyproheptadine or periactin off-label to stimulate appetite, and that's helpful in the patients who have kind of a low interest in food, not in kind of low appetite type form of ARFID. The other kind of common form of ARFID, which I think is very relevant for Williams syndrome, is more of an anxiety type of ARFID, where that's kind of like, you know, fearful of trying new foods, fearful that something bad may happen if they eat, like choking or belly pain. If I think that the ARFID is more anxiety related, then I'm really going after the anxiety. And the specific anxiety medication that we have the most evidence base for in Williams specifically is something called buspirone. And those of you who know me know that I can talk about buspirone for hours, so I'll spare you. Thank you very much to everybody who's participated in research. We also have to acknowledge Dr. Jenny Thomas, who's an eating disorder specialist at MGH and actually innovated the CBT for ARFID protocol. She's been very helpful to our research and clinical care. Many of you know Danielle Renzi. She was Dr. Pober's and my clinical research coordinator for many years and really supported a lot of the work for the SHAPE study, among other studies. And then we couldn't do any of this research without the WSA or people who have generously funded our research. So we have maybe 2-3 minutes for questions, but we'll all be around for lunch if there's anything more you'd like to ask. Barbara and Ashley, would you like to come up? Please go ahead.
Yes, my brother with Williams syndrome, his dad passed away years ago. Since then, he developed achalasia, but also he developed some kind of weird thing where he hides and wants stuff, like he's hiding food, money. He started developing like OCD, like throwing stuff away that's necessary, like plates, clothing. Is there any kind of link? How can we help him with this problem of hoarding food and hiding stuff and denying it? I need malnutrition now.
So where do you live?
So I live in London.
It's not that we can't help you. So I was actually in July at the WSF, the UK Williams syndrome family meeting, and it's just a different set of resources over there. I mean, it's starting with a psychiatrist with knowledge of Williams is, if you lived in the US, is certainly what I would say is the starting place.
I can provide a couple of recommendations. So one thing I will say is that oftentimes folks that have like binge eating disorder, for example, where they might eat like a large quantity of certain foods that maybe most people are trying to avoid or limit, they tend to be the folks that tend to hoard food, or you might find candy wrappers everywhere, or they might be secretive about what they're eating. And that's because there's oftentimes a lot of shame associated with the types of foods that they're eating. And that could be caused by many different things. It could be caused by like emotional issues. It may be caused by maybe they're not eating enough during the day, or maybe they don't have a nice variety of foods that they can eat. So they feel like they need to hold on to the foods that they can. So my recommendation would be to probably talk with an eating disorder specialist to address those behaviors.
I'm finding as my son with Williams syndrome gets older, after your presentation, it's almost like the ovaries at home, and then as you change the residential setting, I'm finding like different aspects of these different disorders. Is it possible that in one setting they overeat, and then there's a residential setting where he's not eating anything, like he's has this avoidance of food for whatever reason? I kind of can't put my finger on. How do you sort of evaluate and recommend or treat as they change? So in the next, say, 10 years, we're probably going to change residential settings a couple of times. How do we keep them consistent and healthy across different settings? What's the recommendation? I've long perspective you have various eating disorders as you age, from ARPID back when you were a baby, so how do we treat sort of across different phases of the life, even healthy?
Yeah, that's a great question. Well, it sounds like, it might be kind of, so potentially some ARFID going on, or potentially some overeating happening. And oftentimes what we see is that sometimes eating disorders can overlap, where we might have situations where people only eat a certain amount of foods or have really picky eating, so that when there are foods that they can eat, they tend to overeat because they're either overly hungry or they haven't had an opportunity to really kind of meet their nutritional needs. So I don't know if it's necessarily specific to a phase as much as really getting kind of like holistic eating disorder care to address all of these kind of intersecting issues. But it's not uncommon to see binge-like symptoms or less control eating or overeating in folks that also have kind of picky eating or food avoidance. We often see that overlap. So I would recommend just a really comprehensive treatment.
I completely agree with everything Ashley said. And I also wanted to make the point that, in our presentation, we make it seem like each of these eating disorders is really discrete. But we actually know in real life that oftentimes people can kind of move from one diagnosis to another and then kind of retain features of one eating disorder. So changes over the lifespan, as you're describing, really aren't uncommon at all. Should we take one more?
Yeah, so Sarah's trying to round up the troops from the next room.
Oh, okay.
So I do see one more hand up.
My daughter's on Mounjaro, and I was wondering if there's a max for Williams syndrome, how high they should go, and also, is there any behavioral side effects of Mounjaro?
So the question is about Mounjaro. So I'm going to defer to the 1 o'clock presentation because the endocrinologist is sitting right there. But I can say, just in case she doesn't, we don't know. I mean, those of us who see lots of individuals with Williams have been sort of jumping up and down for several years saying, we really ought to study this in Williams. And our body composition study, they already have less muscle mass to begin with. Are they losing muscle mass too much? What about behavioral side effects, et cetera, et cetera. So I don't know how much Dr. Stanley will elaborate on it. I hate passing the buck, but it's also, we don't know. And people are anecdotally going out and are on the medication, and we may be having to sort it out afterwards by looking backwards and seeing how well people did and what kind of complications. I mean, Takara, do you sort of agree?
Yeah, I'll talk about it.
She'll talk about it. There we go. All right, well, we are around, and we wanted to have Sarah share updates from the WSA. And for lunch, the box lunch should be out in the hall. Again, the adults with Williams are invited to bring their lunch to the small room to the left that's through this wall. You have to go out. And then the folks without Williams should feel free to take their lunch, mingle, socialize, eat in here, outside if they wish, because it's nice. And then we will resume at 1. Just trying to get your slides.
I missed it, so parents stay here and
Yeah, and lunch will be set up in